Hello everyone, welcome back to Visual Physio. A quick question before we start. If a patient walks in with weak, floppy muscles and another walks in with tight, spastic muscles, how do you know in under 2 minutes, without an MRI, without a single scan, which nerve is actually damaged? That's exactly what reflex testing is built for. By the end of this video, you're not just going to know how to test every major reflex, you're going to know how to read the result like a clinician. Let's start right at the beginning, the pathway itself. Think of a movement like a relay race with 3 runners. Runner 1 is the brain, the command center, the one who decides let's move. Runner 2 is the anterior horn cell, sitting in the spinal cord. It takes the baton and passes it on to the runner 3, the muscle itself. It receives the baton and actually produces the movement. Runner 1 and 2 together make up what we call the upper motor neuron. Runner 2 and 3 make up the lower motor neuron. Drop the baton anywhere along the runner 1 or 2's legs of the race, you get an upper motor neuron lesion. Drop it anywhere from runner 2 onward and you are looking at lower motor neuron lesion. Same finish line, completely different reason for not getting there. Now, let's zoom into the upper motor neuron pathway first. It starts in the brain, travels down through the brainstem, crosses over and runs down the spinal cord until it synapses onto the anterior horn cell. A lesion anywhere along this route can come from a stroke, a traumatic brain injury, a spinal cord injury above the level of lesion, multiple sclerosis or cerebral palsy. So, what does that actually look like in a patient? Here's your upper motor neuron checklist. Increased tone, hyperreflexia, clonus, a positive Babinski sign, minimal to no muscle wasting, decreased or absent superficial reflexes, no fasciculation, a pyramidal pattern of weakness. Notice the theme here. Everything is turned up. Tones up, reflexes are up, clonus is present. That's your upper motor neuron picture. Now, flip to the other side of the story, the lower motor neuron. This pathway runs from the anterior horn cell out through the nerve root, through the plexus, along the peripheral nerve and finally to the muscle. A lesion can happen at any one of these steps. Common causes here include peripheral neuropathy, Guillain-Barré syndrome, nerve root compression or radiculopathy, poliomyelitis, and the lower motor neuron component of motor neuron disease. The clinical signs are almost a mirror image of what we just covered. Decreased tone, hyporeflexia, clonus is absent, Babinski sign is absent, marked muscle wasting is seen because the muscle has lost its nerve supply. Weakness in myotomal or specific nerve distribution, fasciculation, visible twitches are present. So, if upper motor neuron is everything turned up, lower motor neuron is batteries are dead. Hold on to these two phrases. We'll come back to them at the end. Okay, that's our theories in place. Now let's get hands-on. Because the theory means nothing if you can't elicit the reflex properly at the bedside. Reflex testing exists to answer 4 questions. If the reflex is present or absent, is the response normal or abnormal? Are any abnormalities unilateral, bilateral, generalized or localized to one spinal segment? And is there evidence of upper or lower motor neuron involvement? Before you even pick up the hammer, a few prerequisites matter more than people give them credit for. Use of appropriate reflex hammer, use proper wrist technique. Let the hammer's own weight do the work, don't muzzle it. Make sure the patient is relaxed and comfortable. Keep the muscle slightly stretched so it can move freely and know the spinal segment and peripheral nerve supply before you test. So you know what normal should even look like. So now we'll see how to elicit each reflex. First is biceps reflex. You will press the forefinger gently on the biceps tendon in the antecubital fossa and then strike the finger with your hammer. You will see a normal flexion of the elbow and visible contraction of biceps muscle. To elicit the triceps reflex, you will be holding the patient arm and draw the arm across the trunk and allow it to lie loosely in the new position. Then you will strike the triceps tendon 5 cm above the elbow. If there is no response, repeat 2-3 times either side of the original point. you have to see extension of the elbow and visible contraction of the triceps. Moving on to Brachioradialis Reflex. Now you will strike the lower end of radius about 5 cm above the wrist and watch the movement of forearm and fingers. The starting position of this test is as same as the biceps reflex. Moving on to lower limb reflexes, first being knee reflex, there are two methods to test this. The first method is patient lies in supine lying. You will be keeping the testing knee flexed and completely relaxed. Support the knees with one arm, lightly tap the patellar tendon. Compare both sides and observe the lower leg quadriceps. You should see a normal response of knee extension or visible quadriceps contraction. The second method is where the patient is sitting in high sitting and the legs are dangling. So you will see the same response, but here if the patient has pendular response, you can see the excessive extension pattern. Now the ankle jerk. The patient is in supine lying again. You will slightly flex the knee and externally rotate the hip. Support the foot and gently dorsiflex the ankle and then tap the Achilles tendon. Observe the foot and calf muscle. You should see a normal plantar flexion of the foot or contraction of the gastrocnemius and soleus muscle. Moving on to jaw jerk, ask the patient to keep mouth slightly open and relaxed. Place a finger over the chin before the lower lip. Tap the finger downwards with the hammer. Testing in sitting if response is difficult to obtain while lying down. Normal response, slight upward movement of jaw due to masseter contraction. A reflex may be absent in healthy individual. Once you elicit a reflex, how do you score it? The DTR grading scale runs 0 to 4+. 0 being absent, 4+ being hyperreflexia with clonus. 2+ is your baseline. What you are really watching for is drift towards 0 or drift towards 4+. Everything so far has been a deep tendon reflex. There is a second category, superficial reflexes, and these work almost the opposite way in healthy nervous system. They should be present, so if it's lost, that's often significant. The 4 to know: the plantar reflex, the abdominal reflex, the cremasteric reflex, and the anal reflex. Plantar reflex is a classical exam favorite where the stimulus is given by stroking the lateral sole of the foot from the heel towards the base of first great toe. Normal response: the toe flexed downwards, but if big toe dorsiflexes and other toe fan out instead, that's your positive Babinski sign. And a positive Babinski points straight an upper motor neuron lesion. For abdominal reflex, the patient will lie in supine with abdomen relaxed. Explain and demonstrate the test first. Then lightly stroke each abdominal quadrant from outside in towards the umbilicus. Always with a blunt object, never a pin. Normal response: contraction of stimulated abdominal muscles and umbilical moving towards the stimulated side. Cremasteric and anal reflex both follow the same superficial logic. A light stimulus should produce a local muscle contraction. Their absence, particularly alongside other upper motor neuron sign, adds to overall picture. There are few pathological reflexes beyond standard reflexes. There is a specific set when they are present are strong indicator of an upper motor neuron lesion. These shouldn't be present in healthy adult nervous system. Chaddock sign, Hoffman sign, the palmomental reflex, and clonus of 3 to 4 beats or more. That last one is considered clinically significant versus 1 or 2 beats, which can sometimes be normal variant. A Chaddock sign is a diagnostic reflex similar to Babinski reflex. Chaddock sign is present when stroking of lateral malleolus causes extension of great toe, indicating damage of corticospinal tract. Hoffman sign is a neurological examination used to assess the presence of upper motor neuron lesion from spinal cord compression. So, let's put this all together with two patients. Patient A comes in with increased tone, brisk reflexes, clonus, and a positive Babinski sign. Everything we just listed for upper motor neuron. This points to post-stroke presentation, an upper motor neuron lesion. Patient B comes in with absent reflexes, muscle wasting and flexor plantar response. No Babinski. This is your lower motor neuron picture. Consistent with something like peripheral neuropathy. Same test, same hammer, two complete different stories. And now you know how to read both of them. Let's bring it all the way back where we started. Upper motor neuron, everything turned up to 11. Tones up, reflexes are up, clonus is present. Lower motor neuron, the batteries are dead, tones down, reflexes are down, and the muscle wasting is seen because it has lost its nerve supply. One reflex hammer, two completely different diagnoses. And now you are the one who knows how to tell them apart. If this helped things click, hit a like, drop a comment with which reflex you find trickiest to elicit, and subscribe for more content like this. Thank you for watching.